Now, pulpotomy. What is pulpotomy? Basically, the whole amount of no, it is what is difference between direct pulp capping and pulpotomy. And pulpotomy, we also remove a certain amount of pulpal tissue from the coronal. In direct pulp capping, we are not removing anything. There is just a pulp extrusion and over which we place a medicine. But in pulpotomy, a certain amount of pulp tissue is being also used. So, according to Penn in 1995, the complete removal of coronal portion of the dental pulp, followed by a placement of suitable dressing or medicament that will promote healing and preserve the vitality of the tooth. According to American Academy of Pediatrics in 1998, the amputation of the affected or infected coronal portion of the skull, preserving the vitality and function of all part of the remaining radicular part, is pulpotomy. According to Popper, it is the surgical removal of entire coronal pulp, leaving intact vital tissues into the canal. So we leave the radicular portion of the pulp and we remove the coronal portion. What are the objectives of pulpotomy? Preserve the vitality of the radicular pulp to relieve the pain. And what is the rationale? Basically, only the coronal portion is inflamed. The radicular portion of the pulp is healthy. It preserves the vitality of your radicular pulp. All the infective and inflamed part is removed, so there is no further inflammation, and it maintains the tooth in a more physiological condition. Basically, because it preserves certain amount of your natural pulpal tissue. Now, what are the indications of pulpotomy? Pulp exposure is there in primary teeth. A large carious lesion, but radicular pulp is free from tetanosis. There is no interradicular pathology. There is no breakage in lamina dura. There is no widening of your uh, periodontal ligament. There is no abscess of fistula. At least two-thirds of your root line is still present. And in one permanent tooth with vital exposed pulp and incomplete from physis. These are the indications. Now, where we not perform pulpotomy, what are the contraindications of pulpotomy? There is a persistent spontaneous toothache. There is tenderness and percussion, tooth mobility, tooth resorption more than one-third of root length, large caries lesion with non-restorable crowns, highly viscous sluggish hemorrhage from canal orifice which is uncontrolled. So this sluggish hemorrhage which is uncontrollable, that bleeding cannot be controlled from the orifices, that indicates inflammation and inflammation in radicular portion. So if there is signs of inflammation in radicular portion, he does not perform pulpotomy. Hemorrhage from the anterior side is uncontrollable, bleeding cannot be stopped. Now pulpotomy. Vital pulpotomy technique. First is GY, intended to destroy and mummify the vital tissue. There can be single setting by formocrysol, electrosurgery or laser, or two-phase by cryophosphamide, formaldehyde or paraform devitalizing paste. Preservation. Maintaining the maximum vital tissue with no induction of reparative, glutaraldehyde and ferric sulfate. And regeneration. Formation of your reparative dentin, like bone morphogenic proteins, calcium hydroxide and MP. So three types of your vital pulpotomy technique is there. First is devitalization, in which we use formocrysol, electrosurgery and laser, or cryophosphate, formaldehyde or paraform devitalizing place. Then preservation, where we maintain the tissue, but there is no reparative dentin formation. So that is by glutaraldehyde and ferric sulfate. And regeneration, where we place certain medicaments that promote dentin bridge formation. That is calcium hydroxide, mineral um, MTA, and BMP. That is bone morphogenic. Now, non-vital pulpotomy. When we Place formocresol or beechwood cresol over the tooth and tooth becomes non-vital, but the pulpal tissue has been preserved. Classified according to two objectives by D.M. Renly, 1994, revitalization, preservation, and regeneration. In the past, they used formocresol and primarily then calcium hydroxide in immature pulp, but there is contraindication of using formocresol. Medical conditions like heart disease or immunocompromised patients, then swelling of fistula, external and internal root eruption, pathological mobility, pulp calcification. Now, formocresol pulp water. Formocresol was given by Buckley in 1904. Indefinite shelf life, mass, and triggering on effects formocresol and priming. They studied the effects. So, the mixture of formocresol, Buckley's formocresol contains tricresol, that is 35%, formaldehyde 19%, glycerol 15%, water 31%, and three zones of purposing. Broad ESM is a zone of fixation, the upper layer that is a fixation. Broad pale staining zone, coagulation necrosis, and inflammation diffusing apathy, that is a vital. Three zones can be seen. Event place formation all over radical. Now the application time is also important in case of formocresol pulpotomy. So it's according to immersion. A 5-minute application resulted in fixation of tissue while an application stayed in for 3 days caused calcific degeneration. According to Doyle, McDonald, and Michelle, compared formocresol and calcium hydroxide in primary canines and found 95% success after 1 year with formocresol. Now, single appointment formocresol pulpotomy. Inflammation of coronal portion is an indication when contraindication is history of spontaneous pain, profuse hemorrhage when exposed, abnormal root resorption, the two-third resorb, internal resorption, interradicular bone loss, and presence of fistula. It is the contraindication of formocresol pulpotomy. Now the procedure. First of all, we give in local anesthesia, then isolate the tooth by placing a rubber dam with a close-fit hand to remove the calcareous portion. Pulp is exposed. Whole of the coronal pulp is removed with the help of a stone excavator like this. Now bleeding is stopped and radicular orifice is seen. Then we dip our cotton in formicresol and then dampen against the tissue. Then the damped cotton pallet is placed over the exposed radicular portion of the tooth. After this cotton pallet is placed for 5 minutes, after which over the radicular portion the cotton is removed. Over the radicular portion, calcium hydroxide or any other intravenous restorative medicament is placed, and then the final restoration is done. So, see, this is a radiograph showing pulpotomy procedure. Now, in formocresol pulpotomy, there are various histological studies that reveal superficial debris along with dentina chips at amputation, eosinophilic stained and compressed tissue, palely stained zone with loss of cellular definition, area of fibrotic inflammation, an area of normal appearing pulp tissue that is considered to be normal at the apical portion. Now that was a single appointment phlebotomy. Now two appointment phlebotomy indication is sluggish Bleeding at amputation site proves difficult to control. Blood plus in chamber but not at amputation site. Thickening of periodontal ligament, history of pain, and need for short apart. That is uncooperative patient. Contraindication non-restorable tooth, exfoliate skin and toothed necrotic. In first visit, we achieve hemostasis, cotton palate diluted with cortisol sealed in chamber for 5 to 7 days. Temporary restoration is placed. Second visit, removal of temporary restoration, cotton palate, irrigating with H2O2, zinc oxide using cement is placed, and crown is placed. Calcium hydroxide. This boosts to pulp capping but drain for pulp water. Why? Because we have discussed this earlier also. Because in case of pulpotomy, more amount of area is taken up by calcium hydroxide, and there is increased chances of internal resorption. The resorption was ascribed due to a blood clot intervening between the chemical and pulp tissue, not calcium. Now, partial pulpotomy. Partial pulpotomy is basically a small amount of pulp removed, not whole coronal pulp is not. Young permanent method pulp exposure, mechanical bacterium, rationally to preserve vital pulp and normal root closure. According to Marjorie and Steve, partial pulpotomy is going to turn young permanent teeth. Procedure is give anesthesia, isolate the tooth, caries is removed, coronal pulp amputated, hemostasis is attained, temporary restoration is clear. Tooth should remain asymptomatic during recall visit, radiographically secondary dentin compression to be noted, and then again tooth is restored by amalgam compost. Now calcium hydroxide pulp water. Most favored in 1940s and mid 1950s. Pressure and Zander, termed Whiteley technique. This is vital. Demonstrated necrosis of pulp lying close to calcium hydroxide and secondary dentin formation. Pre-existing bone, coagulation necrosis, deep staining basophilic areas of various osteodentine, and relatively normal pulp. Three zones are seen in calcium hydroxide pulp water. Now, what is the indication of calcium hydroxide pulp water? Young permanent tooth owing to its less cellular activity than the primary tooth. Mechanical caries, traumatic exposure with incomplete apical closure. Contraindication is not recommended for primary teeth. Why? Because the point of internal toxin, diffuse inflammation, and internal two points. It is not contraindicated basically. We perform calcium hydroxide in primary teeth, but it is generally not recommended. Now, what is the procedure? First of all, we give anesthesia, isolate with the help of rubber dam. Caries is removed without pulp exposure. Deroofing of the pulp chamber is done. Coronal pulp is removed, it is amputated. Bleeding is controlled. Calcium hydroxide is placed over the orifice and dried with cotton pallet. Quick setting Deadol cement placed over it. Stainless steel crown is placed. Now, what we can also perform is glutaraldehyde, ferric sulfate, MTA, electrosurgery. Or future, we can use laser. Dentine fragments can also be used. And recombinant human osteogenic protein PTFB family can also be used. Bone morphogenesis. Now, glutaraldehyde. What are the advantages of glutaraldehyde over pulp? Bactericidal agent between Bactericidal agent between instrumentation sessions. More diffuse apical and laterally from canal. Fixative agent with positive characteristics of formicosol with less side effects and rapidly from cross-linking health and benefits. So it is bactericidal. So between instrumentation, there is less chance. It creates a sterile environment. Then it does not diffuse apically and laterally from the canal. It fixes the thing. So The positive point of pharmaceutical is fixes the tissue. So glutaraldehyde also fixes the tissue and it rapidly forms cross-linking. Hence the penetration is less. Properties of glutaraldehyde. Superior fixation with relatively little immunogenicity, mild effects on pulpal tissue, lesser systemic distribution, and positive clinical risk. Histological processes, less damage apically and less necrosis, less clearly demarcated zones within radicular tissue, no evidence of ingrowth of granulation tissue, less intense dystrophic calcification limited to coronal portion of canal, fibroblastic proliferation observed immediately below glutaraldehyde fixed tissue in coronal third indicating repair replace. Now glutaraldehyde versus formicosol. Now what is absence of multizones in root pulp? A homogeneous eosinophilic stained complete zone was present below amphitheater surface in case of glutaraldehyde. Round cell infiltration like lymphocytes, plasma cells and macrophages. Below this red normal cell tissue was found. Toxicity, glutaraldehyde is less toxic. Doesn't perfume the pulp to the apex and readily metabolized. That is 90% of the drug excreted within 3 days. It is bactericidal. 3% adequate antimicrobial effect. Antigenicity relatively low. Mutagenicity does not reach nucleus of hepatocyte. How it acts? Still debated. Basically, certain studies say that agglutination of blood protein results from the reaction of blood with both ferric and sulfate ions and with the acidic pH of the solution, the agglutinated proteins from plugs that occlude the capillary orifice. Basis of action as a metal protein clot at the surface of pulp stump, thus acting as a barrier to the irritant component of sulfate as knocked off. Now ferric sulfate. It is also called as Montel solution, 20% ferric subsulfate. From subtypic first used in military hospital in Bordeaux in France, it was proposed as a pulpotomy medicament for vital pulpotomy. Paraquinone solution 1%. Advantages is over formicosol is that 15 seconds for manipulation compared to 5 minutes formicosol. Now MTA. Powder that sets in moisture, pH is 12.5. Setting time is 4 hours and compressive strength is 17 megapascal. What is the action of mineral trioxide aggregators? Stimulate cytokine release from bone cells and it is a potential medicament for pulpotomy, pulp cap with reversible pulpitis and apexis. Edelman, Fluke and Holland in 2001 compared MTA and formicosol in pulpotomy primary tube and showed both clinical and radiographic effects. Ash-colored hydrophilic tricalcium aluminum, tricalcium silicate, tricalcium oxide, tricalcium oxide is present in MTA. Now electrosurgery. Mark in 1993 first performed electrosurgery. Mark and Dean in 1993. 99% success rate for primary molars. What is the procedure? A dental electrode used to deliver electric arc. Cotton pallet removed, electrode placed. After amputation of coronal a cotton pallet is placed. After which the cotton pallet is removed, electrode is placed 1 to 2 mm above the pulp stump. Electric arc 1 second and cool down period of 5 seconds. Pulpal stumps dry and blackened. Shadow over the pulpal stump is placed and tooth is restored by a stainless steel craft. Now laser pulpotomy, that is the future. Mediac laser is used. LA, isolation and excavation, control of the bleeding. Complete hemostasis achieved after it is exposure to Mediac laser at 20 HP and after which, after the laser application, the tooth is restored. Now bone morphogenic protein. Neurist demineralized bone matrix can stimulate new bone formation when implanted in ectopic sites. Nakashima, both bone and dentin will promote dentinogenesis. Dentin fragments can also be used. Recombinant human osteogenic protein, TGF family, OP123 and BMP23456 can be used. What they do is they promote reparative dentin formation. So basically BMP2 odontoblast, the action on odontoblast, BMP4 they act on pulp cell culture, BMP6 on dentipapilla and odontoblast, and OP1 that is osteogenic protein 1 and BMP7 the permanent perforation on dent. Now motile pulpotomy that is non-vital pulpotomy. It is ideally a pulpectomy because we revitalize the tooth. Indication when the canals are non-negotiable, the patient cooperation is limited, inflammatory process is extended towards radicular pulse, and presence of abscess without acute cellulite. What is the procedure? In first appointment, the necrotic pulp is removed, tooth is irrigated from saline, infected radicular pulp treated with strong antiseptic solution that is fluticasol, 4 minutes impregnated with solution, temporary restoration for 1 to 2 weeks. In second appointment, if the tooth is asymptomatic, antiseptic paste of 2-methoxy-4-phenol, methoxyphenol 47% and methoxyphenol 7%, that is basically cresol, is placed over the tooth and that after which formocresol and or camphorated monochlorophenols can be placed over the tooth and tooth is restored and final restoration is done with the help of your stainless steel crown and home visit restoration.